Hello. Welcome to the webcast, Protocols for the Prevention and Treatment of Pressure Injuries, Sustaining Outcomes at the Point of Care. This program is provided by North American Center for Continuing Medical Education, LLC, and is supported by an educational grant from Smith & Nephew, Incorporated. I am Joyce Pittman, and I will be your presenter for today. My goal in speaking to you today is to provide a brief overview of the topics as you see them listed here. These are our learning objectives, so I'll let you read those at your leisure. So we're going to start off our discussion today with the definition of pressure injury. Pressure injury has been defined by the National Pressure Ulcer Advisory Panel, and they updated their definitions recently in 2016. And they have included them to say the following. Pressure injury is a localized damage to the skin and underlying soft tissue. It's usually over a bony prominence or related to a medical or other device. This injury can present as intact skin or an open ulcer. It also might be painful. The injury occurs as a result of intense and/or prolonged pressure or pressure in combination with shear. The tolerance of soft tissue to pressure and shear may also be affected by microclimate, nutrition, perfusion, comorbid conditions, and condition of soft tissue. This definition is important as you are identifying and completing your physical assessment, and I use this definition as a checklist. So think of it before you even start classifying the depth of the injury. Think of the definition as a checklist. So number one, is this a localized damage to the skin, meaning it has clearly defined margins? Number two, is it over a bony prominence or is it related to a medical or other device? Is the device present or is there a history of a device? And then it should usually mirror the shape of the device. And then number three, this injury occurs as a result of intense and or prolonged pressure or pressure in combination with shear. If one of these three components are not present, then you really need to reevaluate if this injury is a pressure-related injury. So let's talk now about the pathogenesis of a pressure injury. There is not great science. It's becoming more and more correct and benchmarked and tested scientifically, but the current thinking is called a bottom-up theory, and this is when external pressure leads to necrosis that first develops in the subacute fat and or muscle tissue, and then it appears later in the skin. It's thought that the external pressure and or shear force and its counteractive force from bony prominences directly cause the tissue ischemia and deformation, leading to deep tissue necrosis. Reperfusion injury due to oxidative stress also adds to this damage. Skin is more tolerant to ischemia than the deeper tissues, the subacute adipose and the muscle tissue. Skin vascularity strongly depends on the underlying tissue support, and severe damage to the deeper tissues impairs skin viability. So muscle tissue can survive prolonged periods of ischemia, but it's more vulnerable to the ischemia reperfusion injury. This was found by Vaden Hoek in 1996. The ischemia reperfusion injury can damage cells through oxidative stress and production of free radicals, particularly mitochondrial superoxide. And that is supported by Liu in 1997 and Shiva's work in 2007. The oxidative stress contributes to pressure injury pathophysiology. So the injury progression may be caused in part by loss of perfusion, oxidative stress, influx of calcium, efflux of alarmins, and other disruptions of the environment. So by this definition and this description, you can really see the complexity that goes into pressure injuries. So let's talk about the etiology of them. Many of you may recognize this model. This is by Barbara Braden in her foundational work and great work that she did for us in her risk assessment development tool. But she has said, and you can see the duration and intensity of pressure plus tissue tolerance will lead to pressure injury. And isn't that true? The duration and intensity of pressure might be the same for two individuals, but because their tissue tolerance is different, one gets a pressure injury and one doesn't. Using the example of maybe a 26-year-old young guy who comes in and he's going to have knee surgery. He's going to have a simple scope, but they run into problems on the table and he ends up being on the table 2 hours. Versus a 79-year-old little frail woman comes in, she has a fractured hip, and she's going to have a 2-hour case, prolonged case for some reason, and she ends up with a pressure injury. And what's the difference? The difference is the tissue tolerance of these two individuals. So there's 4 major reasons why we should pay attention to pressure injuries. Why these are important. Why are they significant to us? The first reason is that this is a common problem. The prevalence in some of our recent studies and even long-ranging studies, it hasn't really changed. You can see skilled nursing facilities, acute care, and home care. It's across the board. Oftentimes we blame our long-term care, post-discharge facilities, but you can see here from this data, acute care sometimes has risen. The length of stay was found to double in one study by Price when there was a pressure injury involved. And Leiter, he has documented that pressure injuries in the elders have been associated with increased mortality rates. People die when they get severe pressure injuries. 70% pressure injuries occur in patients aged 70 years or older. And there's 2 to 6 times greater mortality risk. That is just it's so amazing to me. Mortality increases 6-fold when there's a pressure injury documented. It increases 4-fold even when the pressure injury heals. So are they a concern? Absolutely. A second important reason why we should pay attention to pressure injuries is, of course, the financial reason. CMS attached monetary penalties and issued regulatory statements specific to acute care, attaching these monetary penalties to the development of stage 3 and 4 pressure injuries. It wasn't until then that actually some of our leadership started paying attention. Also, current sources tell us that the cost of a hospital-acquired pressure injury can range from almost $21,000 to almost $152,000. And the estimated cost of treating a pressure injury can be as high as $11 billion a year. So are they a financial concern? Absolutely. The third reason we should pay attention is regulatory. CMS, Joint Commission, various state departments of health have mandated transparency of outcomes to the public and public reporting of pressure injuries. This then can have an influence on reimbursement. The fourth reason is quality and outcome-based reimbursement. The shift from pay for service to these quality and outcome-based payment strategies. NDNQI, which is the National Database of Nursing Quality Indicators, identified pressure injuries as a nurse-sensitive quality indicator, meaning that these are the indicators, these are those quality measures that should improve if there's a greater quantity or quality of nursing care. We're going to talk about that a little bit later. Magnet accreditation, high reliability organizations, and transparency, meaning outcomes are reportable to the public. All of these indicate and lead us to understand that pressure injuries are very significant and are a concern. But most importantly, what if this was your family member? What if this was your mother or your father or your grandparent that developed these serious pressure injuries? We need to recognize the implications of pressure injuries on not only cost, finances, outcomes, transparency, but on the patient's quality of life and health. We've talked about mortality. We've talked about length of stay. What about the psychological aspects of it? What about the social aspects? Many times when a patient has a pressure injury, we put them on bed rest. That cuts them off from all family and other social activities. This poem, I think, is very poignant by Asher. It's old, from 1947, but it just tells the story. The dangers of going to bed. Look at the patient laying long in bed. What a pathetic picture he makes. The blood clotting in his veins, the lime draining from his bones, the scabiella stacking up in his colon, and the flesh rotting from his feet, the urine leaking from his distended bladder, and the spirit evaporating from his soul. Okay, so now we know that they're bad. We know we're all depressed because we've read this, because this happens. We know somebody that had a pressure injury. We take care of people that have pressure injuries. So they're bad. How can we prevent them? How do you do it in your facility or in your organization? How do you incorporate assessment of pressure injuries into your work, into your physical assessment, whether you're a physician, whether you're a nurse practitioner, a physician's assistant, provider, or if you're a nurse? This aspect should be incorporated into your work because these are serious events. The other components that we need to think about, the essential components of pressure injury prevention programs, are listed here. These are the 6 essentials. These are evidence-based. You can see the citations we've listed for this. But this has been out. I would be very surprised if not all of you are working in some type of organization that has something that incorporates all of these components. Number 1, conduct a pressure injury admission assessment. Number 2, assess the pressure injury risk daily. Whatever risk assessment tool you use, you assess the risk. Number 3, you inspect the skin daily, not just on admission, but either daily or on a routine basis. You manage moisture, you maximize the nutrition, and you minimize pressure. And we'll talk about some of the interventions that this might mean. But thinking in your organization or in your practice, how do you address these issues? And how do you provide education to your patients and staff and family? Staying on the thought of essential components, CMS and the NPUAP and also WOC, they have identified that there are these essential components, and they actually used these components when they were defining specifically CMS and then NPUAP, avoidable versus unavoidable pressure injuries. But they are the essential components of how to prevent a pressure injury from occurring. Number 1, evaluate the individual's clinical condition and risk factors for pressure injuries. Number 2, define and implement interventions that are consistent with the individual's needs, goals, and recognized standards of practice. Number 3, monitor and evaluate the impact of the interventions. And number 4, revise those approaches as appropriate. Now you might think about these because you'll see the correlation and the relationship to our previous slide. Number 2 is looking at and defining and implementing interventions. That's moisture, nutrition, pressure redistribution. So they're very similar, but these are the definitions that Medicare uses to define avoidable and unavoidable. For instance, they define unavoidable pressure ulcers as those pressure injuries or ulcers that develop even though the provider had evaluated the individual's clinical condition and pressure ulcer risk factors. The provider had defined and implemented interventions consistent with the individual's needs and goals and recognized standards of practice, even though the provider monitored and evaluated the impact of the interventions, and even though the approaches were revised as appropriate. So it even takes it a little bit further, I believe, than those 6 essentials that were mentioned in the previous slide. But many pressure injury prevention initiatives, when we do the education to staff or we get these initiatives going using these essential components, we show improvement immediately, but sometimes those improvements and outcomes are not sustained. You know, you show improvement for month 1, month 2, month 3 you start to climb, month 4 you start to climb, and before you know it, by the end of the year, you're kind of back to maybe just slightly better than when you started. So you need to think about how can we sustain outcomes. In order to do that, you've got to examine the structures and processes that drive the outcomes. So in these following slides, we're going to talk a little bit about the 4 magnet model domains. I come from a magnet organization, and I strongly believe in the magnet model because it provides that structure process component to help drive the outcomes. So we're going to talk about transformational leadership, structural empowerment, exemplary professional practice, new knowledge, innovation, and improvement. And if there is successful implementation of these elements, will yield measurable positive outcomes. Okay, so we're going to talk about transformational leadership now. Transformational leadership is described as leaders who develop and support organizational values, beliefs, and behaviors to achieve optimal level of success. They can envision where the organization needs to be and can successfully lead the organization, including rapid and delayed adopters. They successfully function as change agents and create a desired future state. Wouldn't it be nice if all leaders were like that? But regardless, in our organization, some examples of transformational leadership, incorporating this transformational leadership component, are as follows. A key leader stakeholder, in fact at the vice president level, was appointed to facilitate and support our pressure injury prevention initiatives at the system level. Pressure injury prevention clinical program facilitator was appointed and designated. Clear expectations were set for benchmarking, outcomes, and accountability, and the leader assisted with removing barriers to achieve these components. Another example was clear reporting structure and bidirectional communication related to the pressure injury prevention program within the nursing organizational framework was identified. And you can see here some examples of how this was done. So at the board level, our safety and risk board, our nurse executive council, our professional practice steering committees, and then we have a wound ostomy continence pressure injury prevention committee, and then that transmits down to a facility professional practice committee, and then a facility pressure injury prevention at the unit level. So again, you can see from system all the way down to facility to organizational unit level. However your organization is structured, you need to have that clear leadership involvement. Time and resources for group meetings and projects are supported. It's not just voiced, but the leadership communicates down to the manager, to the unit level, saying this person or FTE needs to be given 4 hours of time. So it's down to that unit level of doing the work. Communicates these expectations to all levels, similar to what I just mentioned, whether it's to their directors or their managers. And then the support interdisciplinary team development, meaning we have on our pressure injury prevention team at the system level and also at our facility levels, respiratory therapists, physical therapists, IT, dietitians, physician involvement, PCA or our patient care aides involvement. So the second element of an effective pressure injury prevention program is structural empowerment, is incorporating that into your program. So as Magnet defines structural empowerment as the conditions under which care is provided, it encompasses organizational, human, environmental, and physical resources. Policies, procedures, systems, and programs are part of this structure. Structural empowerment is the Magnet model component that addresses how the workplace environment supports exemplary professional practice, new knowledge, and improved outcomes. Components of that includes professional engagement, commitment to professional development, teaching and role development, commitment to community involvement, recognition of nursing. So here on this slide, I've given you some examples of how we have incorporated structural empowerment into our pressure injury prevention program. Our team was established, and as I mentioned before, at the system level we have a team, at the facility level there's a team, then at the unit level. And now most recently we have developed a steering multidisciplinary team. Bidirectional reporting, meaning it goes up and down from the unit level all the way up to leadership and back down, and there's accountability. I mentioned the multidisciplinary approach. One thing that we've tried to incorporate is transitions of care. So specifically at the system level, we have included some of our home care representatives. And if you would have long-term care or you would have a rehab facility, you might want to include those. Case management might be a good example. Then we have tried to incorporate some recognition of excellence at the system, facility, unit, individual. We have quality awards that are presented. You have to apply, and it's a very competitive process, but the pressure injury prevention team makes it a practice to make application to these quality awards. Another thing you need to incorporate is your pressure injury prevention education expectations and opportunities. How is that embedded into your organization, into your new orientation staff, and into your standard and your experienced staff, your annual competencies? We've incorporated into our organization the Wound Treatment Associate Program, which is an educational program developed by the Wound Ostomy Continence Nurses Society. It's a very reputable, evidence-based program. I'll talk a little bit about that, but we have incorporated that into our education. There are other education programs out there that you might want to consider or develop your own. But why, reinvent the wheel when there's some good programs already out there? And then, do you have some kind of professional growth program for your nurses or staff? How does your organization support conference presentations and attendance? In our organization, you have to submit an abstract, and if you're presenting orally, then they offer support. So we don't support people just to go. We want to make sure that you're either contributing something or you're bringing something back to the facility or unit. The third critical component of an effective, sustainable pressure injury program is exemplary professional practice. And that's defined as practice that is designed, implemented, and reiterated over time until it reaches a point of saturation and standardization. Practical methods of conducting work. These are the processes that ensure autonomy, accountability, peer review, supports competence and ethical practice, builds a culture of safety, interdisciplinary collaboration and leadership, methods of quality care monitoring and improvement, and it's defined by your organization's professional practice model. So it integrates the pressure injury prevention clinical practice guidelines and ensures implementation into that clinical practice. So some examples of how our organization has incorporated pressure injury prevention strategies in using the exemplary professional practice component of Magnet is we've got evidence-based pressure injury prevention protocols and plans of care, order sets, and these are embedded into our electronic medical record. Pressure injury prevention is hardwired into the care at the bedside, but also our ancillary areas, our operating room, emergency department, transportation, meaning safe handoff, order sets. We call them triggers or Cerner, your EMR alerts. Is your pressure injury prevalence and processes of benchmarking monthly rather than quarterly. we had a significant improvement when we went to monthly rather than doing the minimum requirement of NDU and QI and magnet of quarterly. And it makes sense, doesn't it? If you're looking, you're going to find things, but you're going to pay attention. If you're not looking and you're not doing a prevalence assessment, you're not going to worry about it if you don't know about it. So again, I strongly recommend a monthly prevalence audit, and a move toward meaningful data would be looking at incidence rates rather than prevalence. Pressure injury integration into your IT, your quality data reports, triggers, e-measures. We did some redesign work with our EMR, looking at specific nursing interventions based on risk assessment. Okay. And then your culture of safety using standardized root cause analysis process. When you do find a hospital-acquired pressure injury, do you have a standardized process of looking at gaps and to determine if best care was given? We use the NPUAP root cause analysis template, which is free. You can just go to the website and find it. And then we use a tool that we've developed and studied and examined called our avoidable or unavoidable hospital-acquired pressure injury prevention inventory. Here's another example. I'm not sure you can see this very well, but this is just an example of some of the work we did that would fall under this category of exemplary professional practice. We looked at some of our nurse-sensitive indicators, and we developed process measures, process maps, meaning these are the processes that it takes to prevent a pressure injury. So, for instance, assess skin. Then the next step would be document present on admission within 24 hours. Complete the Braden risk and skin assessment. If that Braden risk is less than 18 or below, or there's a POA, you advance toward implementing interventions appropriately. If it's a no, we're going to do prevention process measures. If they have a wound, then you're going to go develop the interventions according to the Braden, and you can see the process as it continues on. So process measures, 100% skin assessment completed and documented within 24 hours, 100% accuracy with wound order set completion based on risk. These might be some process measures that you would look at. Some of your standard work that needs to be integrated into your either documentation or discussed in huddles or in your bedside report. So this might give you just an example of some other work. Here's another example of a tool that we developed. This was our flyer. You know, you got to figure out and come up with innovative ways to communicate to your staff because they lose interest. You know, you can't use the same flyer year after year, posted in the bathroom. People stop looking after a while, so you got to change it up. So this was a flyer that we used. We developed these bundle pies, and you can see their numbers. So number 1 is a Braden risk completed on admission. Number 2, skin assessment on admission and every shift. And then using the SKIN acronym that I believe was first developed down at Texas Children's, but it's all over now. But SKIN, surface appropriate. K, keep turning every 2 hours. There is no magic bed. You have got to turn and reposition. I, incontinence management. What are some of those interventions? We have them listed here: breathable pads, moisture barrier creams and lotions, or whatever you use. Nutrition. N is for nutrition. Is it addressed? Has a dietary consult been put into place? Once all those interventions are in place, then if the patient's condition changes, did you revise those interventions according to the patient's condition? And you can see this kind of mirrors thinking back of the 4 components of CMS. So all of your measures and your processes and your structures should really support outcomes. Commit to putting all of the pieces together to prevent a pressure injury. Here's another example of how you might consider communicating those results. This was just a graph that we developed to summarize our outcomes. We communicate, we put this up on the units, we report this out at our professional practice steering committees. But what's a little bit different on this graph is we have inserted some of our tests of change. And we try to see if it correlates or is associated with some of our reductions in pressure injuries. And as you can see, some of them do. So we did some great initiatives toward the latter part of this year, and we have shown and sustained some improvement. So finally the fourth element of an effective and sustainable pressure injury prevention program is the magnet model of component of new knowledge and innovation and improvement. The magnet describes this as a culture of inquiry which operates within an established evidence-based practice infrastructure. So active nursing research efforts add to the growing body of new nursing knowledge. Here are some examples of how we have included this into our pressure injury prevention program, research activities that we are very actively involved in. Wound Ostomy Continence Nurses Society has several grants that they have offered in the past, and we submitted, and we did a randomized controlled trial looking at bowel management devices and methods in the critical care. Then we did a study of translating that into practice. And then, as I mentioned before, we did an unavoidable pressure injury study retrospective in the critical care. So take advantage of some of your professional organizations. Watch for abstracts, watch for grants, for calls, and get involved. We were involved with the American Association of Critical Care Nurses. They do it's called a CSI program for bedside care nurses. And we got a grant, and one of our critical care, there were several nurses, they developed this very cool intervention related to securing NG tubes. They did it, it's called an eye taping method, and you could probably go to AACN and see that. It has decreased our pressure injuries from NGs and core packs to almost nothing. And we did a soft silicone dressing that we used as prevention, and we saw a cost savings of potentially up to almost $2 million. That got our leadership's attention. Then does your program support evidence-based practice projects to improve pressure injury prevention? And here's where I'm explaining the use of the WTA program that we used. In addition to the WTA program that's provided by cost from the WOCN Society, we mandated that each staff member or a group of staff members, they would then develop and implement an evidence-based project. And here are 4 examples of evidence-based projects that they implemented and showed significant improvement in our pressure injury rates. And here are some other suggestions of how you can incorporate new knowledge into the structures and processes using the new knowledge magnet component. I just wanted to throw in, this was our tool that we developed through one of those grants on pressure injury prevention inventory. We're very proud of this work. We're actually presenting this at the NTI in May, so maybe I'll see some of you there. But we completed a retrospective study examining unavoidable pressure injuries in approximately 165 critical care patients. We used the CMS components. You can see them numbered. Clinical condition evaluation. Number 2, defined and implemented interventions consistent with the patient's needs. Number 3, monitored and evaluated the impact. And then 4, revised it. We used the Braden scale, and you can see how we operationalized those 4 CMS NPUAP components. Okay, so that's all that structure, process, outcome stuff. That you have to have the process, structures and process down in order to have a sustainable program. But let's make this real. Let's talk about a case. So this is Mrs. C. She's an 84-year-old white woman, admitting a diagnosis, fractured left hip, type 2 diabetes, hypertension, peripheral vascular disease. She was admitted last night at 11 o'clock. She fell at home, found down, but she was down an unknown period of time. She was found by her neighbor. On your initial assessment, whether you're a nurse provider, you see she's in bed, she's frail appearing, she's thin, she now has a Foley cath. She does not reposition herself, and she resists repositioning. We've all had those type of patients. Surgery scheduled later for today because they had to add her on. And her Braden scale, we're not going to go through the Braden, but it's a 12. So we know that that is below 18, and so that means she is at risk for developing pressure injuries. But also in our clinical judgment, wouldn't you say that she is at risk? What might you initiate after you've done the skin assessment? Not only looking at the surface, but that means you have to turn her, which she's resisting, remember? She hurts, she's got a fractured hip, but you've got to look at her bottom, or you've got to see and ask her what position was she lying in that she was found down in. How many of you have seen them? They come in, they've been found down at home, unknown period of time, and everything, there's purple discoloration all over their left side. I bet they were on their left side, wouldn't you? So again, using your clinical judgment. How long was she in the emergency room? And what was her activity level even prior to this fall? So we need to think about what interventions are we going to put into place. I like the acronym SKIN. It's easy. So skin, surface selection. What surface is she on now? Do you know the beds in your organization? What type of beds are on your unit? Most organizations, I would hope to say, that they have standards. For instance, critical care. Most organizations now are going toward a low air loss redistribution surface. So you're higher end in your critical cares and in your PCUs. And then you can phase down in some of your med-surg areas or your other areas. But don't forget about the emergency room. Those thin carts that they're on, what resources do they have to provide better surface selection? Keep turning. There is no magic bed. I can't emphasize that enough. Don't let anybody tell you there is. You still have to reposition. Even the air fluidized beds, you have to reposition. And then I is for incontinence management. What type of incontinence management do you have available to you? We should be using some kind of breathable pad. We should not be using diapers that just encapsulate and close everything up so we can't see it, but something breathable. And then nutrition. What are we going to do for nutrition? Now she's NPO because she's waiting for surgery. How long is she going to have to wait? What if she's bumped? And now we're going to be going on 24 hours. So just think about nutrition and what's involved. And here I've outlined them. I don't think we need to go over them again, but again, know your beds. We are going to go over them. Turn, turn, turn. There is no magic bed. The other thing to think about is prevention dressings. And we're going to talk more about them, are foam dressings. There's evidence that shows us that these help redistribute the pressure and also minimize the shearing effect. So you really want to think about incorporating prevention dressings. Providing adequate fluids. Also consider medical devices. Mentioned on this patient, she has a Foley catheter. Make sure she's not lying on it. Making sure if she's got an NG or whatever, if you're putting your SCDs on, your sequential compression devices, do they adequately fit? If you've got ortho in your organization, braces and casts and splints, they need to be removed so that you can look underneath them on a routine basis. So as I mentioned, there is some evidence for the use of prevention dressings, and that's growing. Recent guidelines for the NPUAP and the AHRQ on the use of foam dressings, along with a comprehensive prevention treatment protocol, are available. So you need to just pay attention and consider the use of these prevention dressings. They can reduce the amplitude of shear stress, as I mentioned. They can effectively redirect these forces to wider areas, and the dressing materials reduce shear force. So again, really consider, I know sometimes the dressings add cost, but if my critical care areas, I'm not going to put it on everybody that's an 18 or below, because that's everybody in the unit. You might think of specific criteria that it makes sense. In our situation, our criteria was critical care going to OR. We had noted some pressure injuries in those OR cases that were greater than 4 hours, open bellies and open sternums. So those were the beginning criteria that we used. And as I stated below, it decreased the cost, potential cost of potentially up to $2 million over the time frame that we looked at this. There's a quasi-experimental, a convenience sample of 90 critical care patients to compare the pressure injury development. They were randomly allocated to one of 3 groups: repositioning, routine management, hydrocolloid, and foam dressings. And they found that the repositioning routine management group had the highest incidence of pressure injuries, followed by the hydrocolloid group, and the foam dressing group recorded no pressure injuries. So conclusions, and you can see with this study, is that hydrocolloid or foam dressings may be used and may be appropriate. So you have to look at your population. Here is another example of some evidence. This is one of the few randomized controlled trials to investigate the effectiveness of multi-layered soft silicone foam dressings in preventing ICU pressure injuries when applied in the emergency department to over 440 critically ill patients. So this was a pretty strong study, and they found fewer sacral and heel pressure injuries in the intervention groups than in the control group. So their conclusion was that multi-layered soft silicone foam dressings are effective in preventing pressure injuries in these critical care patients. Again, here's another one, a prospective randomized controlled trial in the ICU beds. And they compared the difference in incident rates of hospital-acquired pressure ulcers in 366 critically ill patients treated with preventative care and a foam dressing versus the control group, which was usual care. They found the incidence rate of the pressure injury was less in the intervention group compared to the control group. So again, indicating that pressure or these prevention prophylactic dressings might be something you want to incorporate into your practice. There was another a systematic review that looked at a single high-quality randomized controlled trial, growing number of cohort, weak randomized controlled trial case series. The introduction of a dressing to prevent pressure injuries may help decrease pressure injuries associated with medical devices. So there was no firm clinical evidence at this time that showed one dressing was more effective than others. But here is some of the evidence that you could use to rationalize and to give support to incorporating the use of prevention dressings into your care. So, in summary, for these prevention dressings, when you're selecting a prevention dressing, you need to consider the ability of the dressing to manage moisture and microclimate, the ease of application and removal, the ability to remove the dressing to reassess the skin. These dressings can stay on for up to 7 days, but you need to be reassessing the skin, so you need to peel them back and look. And then the thickness of the dressing if you're going to use them under some of the medical devices. Sometimes that can increase pressure or they're not thick enough. So just consider that when you're selecting a dressing. All right, so that's pressure ulcer prevention, and that's a big piece of it. But we want to briefly look at components of pressure injury treatment. These, the components should include an accurate diagnosis and classification of the wound, assessment and monitoring of healing, pain assessment and treatment, wound bed preparation, assessment and treatment of infection and biofilms, and use of biophysical agents, and possibly surgery. We're briefly going to look at the first 4. So looking at accurate diagnosis and classification, first you've got to determine if this wound is pressure related. Remember my checklist that using NPUAP definition. Is it localized? Is it over a bony prominence or due to a medical device? And is it due to sustained or prolonged intense pressure or shear? That will clarify many times whether this is pressure related. Differentiate this wound from other types of wounds. Is it moisture related? Every wound on the buttocks is not pressure injury. Use the NPUAP pressure injury classification. It's evidence-based, and there is a wealth of information. There's a website. Each stage is clarified based and classified based on recent research and expert clinical consensus. You can see their process. This new system that they revised and published 2016 allows healthcare providers to identify and treat pressure injuries earlier and more accurately. It includes classifying or staging these pressure injuries caused by medical devices, and it clarifies not to stage pressure injuries that are over a mucous membrane. And if you think of it, those injuries, mucous membranes, are different. They're not skin. The staging classification is developed on and based on the layers of skin, epithelial, dermis, subcu, and mucous membranes is different. So it makes sense. Do not stage pressure injuries on mucous membranes. So the NPUAP, in collaboration with CMS, developed this new staging system, and I mentioned some of the highlights, and I'm not going to reiterate them again. But the key difference on this slide, it talks about the updated staging system includes, and you can see they changed from Roman numerals to the standard numerical, 1, 2, 3, 4, unstageable deep tissue pressure injuries. Those would continue to be the stages. And then, of course, you have the mucous membranes, different category. It is not staged. So the second component would be assessment and monitoring of healing. You've got to do a complete comprehensive initial assessment, and then you need to reassess this individual, the injury, and the plan of care on a routine basis if this injury does not show healing as expected. There are a number of tools that you could use to use a standardized approach. This assessment should be done at least weekly, but saying that, a caveat is think about the setting that you're in. Home care, I think that would make sense. If you have a significant pressure injury, you would be seeing them weekly. In the long-term care setting, I agree. Providers, that's a little bit different. You're going to be seeing them on a routine basis, but you should be having some communication and reporting if this of your nursing and others that are caring for the wound, if there is a deterioration or the condition changes. One thing you really need to pay attention to is darkly pigmented skin is different. It is different, sometimes difficult to determine variations in color. So you need to look at the skin temperature, tenderness, change in the tissue consistency, and if there's a level of pain that is identified. You need to also consider pain assessment and treatment. You need to complete a pain assessment on adults and children using a valid and reliable tool. You need to incorporate equipment, positioning, and postures to minimize that pain. You need to select dressings, wound dressings, to minimize pain. Again, here's another example where you might consider the use of foam dressings that have a silicone border that would minimize medical adhesive skin damage. You need to consider non-pharmacologic and pharmacologic strategies, reduce procedural pain using either topical or systemic management options. You need to think about the chronic pain and manage to that level, and then you need to educate your individuals and families in alternative strategies, visualization, relaxation techniques, etc. The next component you need to think about is wound bed preparation. This is a holistic approach to evaluating and removing barriers to wound healing. It's characterized by ongoing debridement, reduction of bacterial burden, and management of exudate. The tissue management, you need to think about cleansing and debridement. What am I using? How am I doing it? Infection and inflammation control. Think about different levels of contamination or bacterial load. So contamination, colonization, critical colonization, local infection, systemic infection, and sepsis. This is a spiraling, usually, event that sometimes you can consider tissue management in your cleansing, and debridement will help keep this infection and inflammation control in check. Consider the use of topical antiseptic cleansers in order to keep that bacterial burden minimized, and then moisture balance. Choose the most appropriate dressing to manage the exudate from this wound. So here's some types of prevention and treatment type dressings. These are those advanced dressings. They've been out. We still call them advanced type dressings. I'm not going to read off the list, but hopefully you're familiar with some of these options for treatment of your various wounds you care for. But we want to focus a little bit on our foam dressings because they have, we do have new evidence related to them. International pressure injury guidelines recommend considering foam dressings for use on exudative stage 2 and shallow stage 3 pressure injuries. You want to make sure that you're using just the minimum number of dressings when you're packing a deep cavitaceous type wound. You don't want to lose anything in these wounds. Consider using a gelling foam for those wounds that are highly exudating. You can consider using foam dressings on full thickness wounds, stage 3 or 4 ulcers with moderate or heavy exudate. The dressings can be changed up to 3 times a week, foam wound fillers up to once a day, and they can also be used as secondary dressings to absorb some of the exudate. So, in conclusion, an effective and sustainable pressure injury prevention program can be developed, and I recommend using the 4 magnet model domains of transformational leadership, structural empowerment, exemplary professional practice, new knowledge, innovation, and improvement. If you do this, successful implementation of these elements will yield measurable, positive, and I dare to say sustainable positive outcomes. Components of pressure injury treatment include accurate diagnosis and classification, assessment and monitoring of healing, pain assessment and treatment, and wound bed preparation. So the triple aim across all of our practice and our healthcare is to improve health, improve patient care experience, and contain costs. I want to thank you very much for attending and listening to me. At this point, this concludes my presentation. Thank you very much.